I think we have Dr. Sowmya Peri back with us, and she'll be speaking about to prevent and to protect is better than to repeat and repair, early management and recent advances in keratoconus with CXL. Can we have a slides up on stage, please?
Start? Okay. So early management and recent advances in the management of keratoconus with CXL. So we are all aware about the indications, and that we know that we need to take stage 2 and stage 3 classification of amseclumig for CXL if possible. So patient education is important. It's necessary to tell them that it's not a refractive surgery. Early treatment is better for prevention and preventing rather than fixing the problems, and patients usually need spectacles or contact lenses even in the later stage. Few cases even may end up with corneal transplant. We are well aware about the Dresden's protocol. I'm not going into that. So coming to the recent advances, CXL protocols to improve oxygen diffusion. So accelerated cross-linking is based on the principle of Bunsen-Russell law of reciprocity, which states that the same effect can be achieved by either applying a higher intensity for a shorter duration or a lower irradiation for a longer period, which avoids excessive stromal thinning and endothelial damage at a constant radiation exposure of 5.4 joules per centimeter square. But the demarcation line which is achieved with ACXL group is pretty shallow compared to that of CCXL group as seen in ASOCT. So in coming to transepithelial cross-linking, this allows corneas with advanced keratoconus to be treated. But the challenges being riboflavin does not penetrate the intact epithelium, and intact epithelium also diminishes the diffusion of oxygen, and the demarcation line is also very shallow. So trans-epithelium cross-linking protocol with enhancers like chemical enhancers, iontophoresis, femtosecond laser-assisted trans-epithelium cross-linking has proven to be beneficial. The advantages of TECXL being reduced risk of infection, less corneal haze, and fewer delays in epithelial healing. So iontophoresis is a non-invasive technique where a small electric current is used to facilitate penetration of riboflavin, which is a negatively charged molecule, to increase the efficacy of TECXL. So studies comparing CCXL and ICXL in early stages have shown ICXL to be effective in halting progression and achieving stabilization as compared to that of CCXL. Also, the demarcation line which is achieved in ICXL is shallower, and patients achieve better contrast sensitivity compared to that of CCXL group. So in pulse UVA irradiation, with a predetermined on and off pattern, this enables better diffusion of oxygen into the stroma and the subsequent greater effect. So although pulse CXL shows promising results, as we can see in the studies, the exact duration of pulsing is debatable. So CXL protocols for thin corneas. Hypoosmolar cross-linking. Cornea is based on the principle that corneal stroma has a normal swelling pressure of 50 to 60 mmHg. So when it's exposed to a hypoosmolar solution, it can swell up to double its thickness. So it's indicated in those corneas where the thinnest pachymetry is less than 400 microns post-epithelial removal. So with the hypoosmolar cross-linking, there was reported stabilization in terms of mean K value and BCVA with no endothelial cell loss and stromal scarring. Hyperosmolar riboflavin causes reduction of central corneal thickness and visual acuity observed in patients with pseudophakic bullous keratopathies. So contact lens assisted CXL, CXL, where the indication being stromal thickness of 350 to 400 microns after epithelium removal, the mechanism being precorneal riboflavin layer, contact lens help in endothelial protection. The advantage being it's independent of the swelling properties of the cornea, but its limitations being riboflavin-soaked contact lens reduces oxygen availability and reduces the surface irradiation levels by 40 to 50%. So what is LASIK extra? LASIK improves the quality of vision, but it reduces the biomechanical strength of the cornea. So combining LASIK with CCXL enhances the biomechanical strengthening of the cornea along with improving the quality of the vision. So LASIK with concomitant half-fluence, high irradiance cross-linking has been shown as a promising treatment modality with significant improvement in refractive stability and possibly reduced incidence of post-LASIK regressions. So CXL protocols for anti-infective applications, photoactivated chromophore for infectious keratitis. It's based on the mechanism that disinfection of microbes by UV light and tissue stabilization can be achieved, and this helps in treating corneal ulcers which are not responding to maximum topical medications. So in a study conducted in Arvind Eye Hospital, Madurai, they have shown that combining CCXL with fungal keratitis regimens and combining CCXL with bacterial keratitis regimens have given promising results. So what are the CXL protocols for optimizing visual acuity? Customized cross-linking. In these studies, they have concluded that greater efficacy of smaller diameter cone-centric treatments for reduction of corneal curvature and higher order aberrations can be achieved, and the greater corneal surface normalization also leads to superior visual results. So TCAT procedure, topographic guided customized epithelial debridement of the keratoconic cornea, sparing the epithelium over the apex of the cone. So the intact island of epithelium soaked with riboflavin causes UV attenuation and acts as a protective shield over the thinnest corneal point. The paracentral cornea, where epithelium is removed, allows better penetration of the riboflavin, resulting in increased biomechanical stiffening effect, as conducted by a study by Shetty sir and all. So in Athens protocol, basically we are combining PRK with the combination of CCXL procedure to maximize the refractive normalization along with ectasia stabilization in young keratoconic patients, so that it broadens the number of potential candidate cases that would have been limited to employ this technique due to tissue thickness limitation factors. So what is Cretan protocol? In this, we combine transepithelial PTK and CXF, and this has found to be safe and effective in keratoconic patients over a long-term follow-up. So in ICRS with CXL, Kera ring intrastromal corneal ring segment insertion assisted by femtosecond laser performs simultaneously with corneal cross-linking. So this resulted in improvement of visual, refractive and topographic outcomes. So what is epi-off lenticule on CXL? It's a technique of tailored stromal expansion in corneas with pachymetry is less than 400 microns, where a stromal lenticule which was removed from patients undergoing SMILE for myopic corrections is used, and the center of the lenticule is placed over the apex of the cone as seen on topography, and conventional CXL is performed. So what is the future of CXL? What lies ahead for us? So basically it is to understand the relationship between riboflavin, oxygen and UVA. The newer accelerated protocols and combination treatments have opened up many options with far-reaching implications on the way we approach ectasia and refractive surgery. A greater degree of customization of treatments will enable us to achieve better refractive outcomes while maintaining a higher level of safety. Thank you.
Hello. So recently there is one more protocol published about SEP 400 protocol, amnomogram. So people are even trying for even thinner corneas like 130 microns, 140 microns. They are just decreasing the time of irradiation time, so that they can get a shallower demarcation line, and there might be some better stiffening of it. Regarding this, I would like to ask ma'am's opinion.
Yeah, so we've just recently started a study to see the effects of sub 400 protocol because we tried it in a few patients. I think once we do this, it's important to know the different concentrations of the riboflavin solutions that we are using. You know, because and we've noticed this, we've published this as well, that once there's a difference between the way a dextran containing riboflavin works vis-a-vis an HPMC containing riboflavin works vis-a-vis one which doesn't contain all of these. So because HPMC causes a better penetration but a much thicker effect, so it causes almost predesmatic demarcation lines. So while earlier it was believed that HPMC is good for thinner corneas because it doesn't desiccate the cornea, but once it's causing such deeper lines, that itself remains a cause for concern. So it's important to know which solution we are using. The sub 400 protocol they have mentioned has a solution which has neither dextran nor HPMC. So we have to be careful about the solution we are using. And there is also uh, a vitamin E containing the TPGS containing riboflavin, which is now I think currently available. It's somewhere down south, only down with Bangalore. So we are planning to study that as well. But it's important to know the solution you are using and then for how long to use it. It's not all procedures are not the same, and you cannot compare all procedures. And a greater flattening doesn't always translate to a better outcome. Sometimes you see greater flattening and patients actually lose vision, and because you alter the curvature too much, a lesser flattening sometimes leads to a better stabilization as well as a greater improvement in vision as well. So that's something I think we need to keep in mind. And then there are so many things for thin corneas. All of them work, I think, to an extent. It's just that we don't have long-term follow-ups either of these. Thank you.
Ma'am, can I make a comment?
Yes, please.
So for the thinner corneas, actually, we also, a lot of these patients who want something to be done, but when we can neither do corneal transplantation are actually requiring treatment. So like you said, Ricriolin is not commercially available in India. So the sub 400 protocol. So we looked at another data from Mazzotta's group. So they have published M protocol, wherein they've collected all the data or published cases of cross-linking that has been done in lesser than 400 micron thickness. And then they've retrospectively studied the demarcation line level and then given the advice on what could be followed, how many minutes lesser or more. So that we did in 2 cases and we've had good results. The patients have been stable for the last 3 years now.
All of these, I think, basically essentially follow the same principle. You are customizing either the energy or the time so that ultimately you are delivering the same amount of energy. So that's why I said, like, I think all of them work to an extent. And the role of oxygen, there was a lot of hype about oxygen, and now there's again, because I was recently at ESCRS and Dr. Farhad Hafezi, who's just published this, he started with the oxygen and now he himself has started saying that probably the oxygen is not required so much because it's not able to diffuse in the time that we are able to give. Again, we are doing a study there and we've seen that the demarcation line with oxygen is definitely deeper, but you do get it otherwise as well. So I think there are too many nuances.
We're
which still
waiting
need to
for
be worked out.
from institutes whether
Yeah,
regarding